We'll just go quickly to the budget of the country. 4 trillion. How much is it for medical interns? 1.4 billion. I mean, that's a drop in the sun. Some of the items that have been done, for instance, let's use renovation of State House. You can pay interns for 1 year. That was the budget. Some of the leakages in our budget. I mean, there is, if we agree that this is the money we have, but if you tell someone you can't pay them, but he can see that some money is getting lost, other things are being prioritized above the most important thing, then that is calls for industrial action. He told people in previous crime, your governor will come and go, your doctor will still be there. Your president will come and go, and your doctor will still be there. Uhuru has gone. Now we have a new president. But the doctor is still the same one treating the same people.
A team of doctors, myself included, Dr. Elias and Dr. Frida Nduati. Dr. Elias, the founder, and Dr. Frida Nduati, the chief editor, and other team members who also contribute. We basically delve into the highs and lows in the world of medicine, not only in dissecting medical mysteries, but also in storytelling and everything in between. We are glad to have our first sponsors of the show, Tamal Healthcare, a medical center offering general outpatient and specialized cardiac care, offering 50 heart screening procedures in the spirit of Ramadan and Eid, located at Tigoni Road opposite Kilimani Mall, where the timelines will be communicated through our social media pages. You can interact with us by subscribing and liking, as well as sharing to our comments, and as well express your views on our social media platforms down below. Now, on today's episode, we are joined by the current Kenya Medical Association president, consultant, obstetrician, gynecologist, a healthcare advocate, CEO at Exela Healthcare, board member Amnesty Kenya, husband and a father, Dr. Simon Kigondu. Karibu, Doc.
Thank you very much.
And how do you see the place?
I'm very intrigued and I'm very impressed by the direction you are taking. Running a podcast myself, I'm very impressed, and I see you are up to that. I'm very happy with, and I asked one of you how you came up with the name, the Laughing Lab Coat.
Yes.
That's intriguing. How did you come up with Laughing Lab Coat?
We basically saw a struggle where the most commonly seen things, especially within the youth, it was either like videos, dancing. No one was really interested about their health, of which, as you grow up, things just come. So we saw that niche and said, Kenyans don't really know what is to expect. So I'd rather we tackle it and educate the community, but with a sense of humor displayed hapo chini. So that was the inspiration behind the name. And I think so far, so good. So usually when we start the podcast, we usually start with a fun fact. Today's fun fact would be, did you know when the human blood vessels are laid end to end, each of them zikishikanishwa pamoja, they could cover the Earth's circle twice. Inazunguka. That's an individual human, an adult human. Kichukua mishipa zake uzishikanishe, it will cover like the circle of the Earth mara mbili, the circumference. So you would say the human anatomy is quite interesting and amazing. And now on to today's discussion. We have a huge crisis. We cannot call it a strike at this point. We have a huge crisis. And 2 minutes, like a couple minutes, you saw me go down. I invited one of the patients who posted herself on social media so that we talk and we see what's going on. And I listened to her struggles, and I know I wouldn't want to go and delve further into the diagnosis and what she's suffering from. But if it's something that if she does not continue with her clinics and the services she was getting, the disease process worsens. So that is one individual. There are so many others. We've had the deaths of the daughter to Mary's deputy speaker, Melissa McKenna. We've had the story of a 1-year-old baby, an infant, pass. All this and numerous other cases, all this because of lack of accessibility to healthcare. Yet you only have two things to deal with. Basically, one thing, an understanding between the government and the doctors. Now, to start, what would you tell the regular Kenyan watching this, knowing that the crisis is there, the doctors have cut, the government is making it political? What would you tell them?
So again, thank you very much for inviting me to this podcast. In health and any death or sickness is unfortunate. And if should someone suffer any form of death, it doesn't matter who it is in society. The first thing that the community should do is to condole with the family. So send messages of condolences and send support to anyone who may have suffered death or illness as a result of inaccess to healthcare services. That said, we need to tackle who is responsible in the death or the sickness of a person. So, for instance, if a doctor is in treating a patient and maybe the patient dies, that particular death, and they are with the patient and all, that particular death can be attributed, as in you can try to look for some relationship between the doctor and the death. But your question goes directly to responsibility. Who is responsible for access to healthcare? If a doctor is not present at a hospital and a patient dies, that responsibility is not his. He's actually not responsible. So that is actually one of the reasons why, if, for instance, your body is called an industrial action, you actually should not be there in the hospital. Because if patients now die while you are there and yet there is an industrial action, then you are responsible because you are there. Yeah. But it is the responsibility of the government, for instance, to ensure that there are doctors in hospitals to treat patients. So if patients die as a result of lack of doctors in a hospital, the responsibility squarely lies on the government or whoever is the provider of human resources for health for a health facility. That once you have that understanding, then you're clear. Then you will not be guilt tripped that, oh, people are dying and you are not. No, you are not there. So if the government fails to post medical interns, then the medical interns are not available at the health facility. And therefore, if someone dies at a facility where a medical intern should be, then the responsibility is for the government. So how do you solve that? You post them there. You post the doctors there.
And in the recent days, we saw the government take a position and try and pay some money to the union and the doctors board.
Yeah.
However, there was still not an agreement, and they even drafted letters asking these interns to come and pick. But we also know that the union wouldn't really prefer these doctors to go pick. What's your take on that?
Yeah. So the current industrial action, one of the major tenets that is pegged on is a problem that the government itself costs. And the government itself costs and then is trying to claim is a problem. Medical officer interns or junior doctors are employed at job group L in the civil service scheme of things with all the benefits that are ingrained in the collective bargaining agreement that was agreed upon and filed in a court of law in 2017. What Kenyans need to know is that that is a legally binding document. And one of the reasons you sign collective bargaining agreements is to protect yourself from exactly what we have seen now. You have a new government who think that things should be run differently, and they sacrifice you literally. So if you have a document, then you can go back to an arbiter, in this case, a court of law, and saying, we signed that interns should be employed and paid at this job group, which is L currently, and these are the allowances, these are the working conditions. If you have an opportunity to read the collective bargaining agreement, which I must confess I was part of the negotiation of this, and that's sort of one of my achievements when I was part of the executive, has lists everything that should be done in the relationship between the doctor working and where they are working. So for the government to come and try to rubbish it, again, is setting a bad precedent. And this is not the first time. The previous government also did that. So this is like a repetitive cycle. When you have a new administration, they try to trash a collective bargaining agreement, which are agreements that are very protective from such exploitation, so to speak.
So we know if it's a recurrent problem where Uhuru's government took over from Kibaki's, and then now Ruto's government now takes over, but we still have that tussle. How do we sort that out? To avoid easy problems and avoiding the strikes? Because if it's a recurring problem, that means every election, new president coming in, be sure to see that doctors will strike because of an unfulfilled agreement.
Yeah. So we need truthfulness, and medicine is needs to be looked at, and it is a social good. The work of a government, especially, is to actually take care of social goods, and social goods are not necessarily profit making. Therefore, we should not look at medicine as a means to profit. And therefore, that argument of, oh, let's reduce the salary of doctors and let's do that. Actually, a report in 2017, I can't remember by who, probably PricewaterhouseCoopers, actually put the starting salary of a doctor at 400,000. That document was quickly shelved and hidden because it actually showed the truth of what an entry doctor should have and subsequently what other doctors should be paid. Of course, it was hidden. So this current scenario we are having, the problem is the government really wants to force underpayment of doctors. So they are using all sorts of tricks, such as calling them student doctors. It's just calling a dog a bad name so that you can kill it. The pay for doctors has gradually been improved over years because when I entered personally as an intern, I used to earn very poor pay. And the Kenya Medical Association then gave a document to the ministry that helped the pay of doctors and actually other health workers improve slightly. And this, if you, the period between 2002 and 2010 dramatically improved health service delivery within the country. And therefore, it shows that a direct relationship is there between pay and service delivery. And therefore, currently one of the problems we're having there, it is impossible, and I'm sure the interns who have worked as interns to get a pay cut, so to speak, they will not be able to survive. And as Kenya Medical Association, our biggest problem with that is actually not the pay cut. It's actually the impact on professionalism. We have had people who have done medical internship for free. Luckily, it's not doctors, but other cadres. And the unethical practices that
Arise.
arise as a result of that then become a danger to both the patient and to the profession. And this is what we are avoiding. We are avoiding someone else who is not a medical doctor trying to dictate indirectly how medical practice should be done. So if we look at it from a professionalism point of view, then we will ensure that doctors are paid what they're supposed to be paid.
You've raised the point where medical doctors, non-medical people making medical related decisions. But within the Ministry of Health, we have Dr. Patrick Amoth.
Mhm.
He did his interview, and during this interview, I think you watched it. We saw that he was basically, obviously, we know where his ties and relationships lie, but his message that he was putting across was more that yes, the pay cut should be there. Yes, whatever the ministry is trying to do should be there. And the quality of medical doctors who are now going into internship that is being produced has become a business by universities. How do you put that across? Do you think he has a point or he doesn't?
Yeah. So put a good man against a bad system, and the system wins 100% of the times.
Okay.
So a long time ago, the Director General was at the level of the Attorney General and was actually the one directing the direction of the health sector of the country. Today, it is not. Today, the Ministry of Health is not acting as the Ministry of Health. It is probably getting instructions from, and that becomes very difficult to operate. So I cannot judge you if I don't know what authority you have been given. I cannot judge you. I cannot say, oh, this person is saying. So it is out of step for the DG to actually be saying what it is. But you can see it is some force behind
Yeah.
him. It
It
is
was
not
it
him.
was not looking comfortable.
It is not. Of course, even when technical people are not looking comfortable in what they have been forced, and it was not him who said that first. They had started with the cabinet secretary of health, and that did not go well. And you can see that a lot of things went south. So the current situation is try to get someone who is looking technical to say the same things, but the push is not from the Ministry of Health. It is obvious what should be done, and people are not, the people being told to say what they are saying do not believe in it.
Where would you say this push is coming from?
It is not for me to to sort of say the Ministry of Health would need to tell us from where they're getting instructions. But what is clear is that they're really pushing the narrative. If you go to the extent of calling a medical officer intern a student intern just to justify pay cut, then that's a problem. So the other problem that we are seeing here is that they're trying to classify doctors with other cadres. The cadre wars are traditional. They've been there where, and actually cadres do not have wars. Everyone actually knows their specific duties. But other people want to show the other people that it's like you're being favored. So for instance, when a doctor is paid higher than, for instance, a clinical officer, then someone else comes and tells them, by the way, you should
No,
be
not
paid
Georgia.
the same as. So it's incitement, you get, and it's not a kind of, so it's a perceived war for people to get on that. So when for instance, they went and gave a list of interns' pay, medical doctors have never been in that list where interns pay is determined by the Salaries and Remuneration Commission. They've never been, because they have been in the CBA, they are employees, they already have a scheme of service in Job Group L. It is the other cadres who previously were not doing internship. Then when they started doing internship, then they needed some form of scheme of service or a pay to define what pay is. For instance, clinical officers never used to be paid, very unfair. And therefore, when now payment, it was said, no, you cannot work without being paid, then those schemes of service. So when you lump that and start saying, oh, you need to pay these people this amount of money, it's being cheeky, so to speak.
Many doctors, student doctors, children, not children rather, but medical students are coming and looking for the person who is responsible. We already know it's the Ministry of Health.
Yeah.
Do you think they are now under legal basis to be sued for these deaths that have happened in the country during this period of industrial action?
So those are two different questions. So there is the question of responsibility, which we have said. Any sort of deaths or sicknesses, aggravations that happen during an industrial action, then you go and find out who is the cause of this industrial action, who is the cause. And as we said, it is the responsibility of government to ensure access. And one of the ways of ensuring access is to ensure that you have a harmonious relationship with the people who are providing the service, which is the doctors. So on an individual basis, I mean, of course, the government would be liable for a suit. And for reason why. One of the reasons that this industrial action is happening is as a result of failure by government to abide to court orders. So, and that is a bad precedent. A government should not fail to abide to court orders. So, it's complex, and that's why there are no simple answers like, oh, you're the one at fault, the doctor is at fault, the government is at fault. But when you look back and trace back to the genesis of some of these issues, then it is clear what should be done and the basis of this. For instance, when the government claims there is no money to pay interns, we'll just go quickly to the budget of the country, 4 trillion. How much is it for medical interns? 1.4 billion. I mean, that's a drop in the sun. Some of the items that have been done, for instance, let's use renovation of State House. You can pay interns for 1 year. That was the budget. Some of the leakages in our budget. I mean, there is, if we agree that this is the money we have, but if you tell someone you can't pay them, but you can see that some money is getting lost, other things are being prioritized above the most important thing, then that is calls for industrial action.
We've seen the article, I think it was on Daily Nation, which portrays, I think, the governor of Kirinyaga and the assets she has acquired and with what pricing that was tagged there. Yet, it's like preaching water and drinking wine. You're saying the government is broke, but you who runs the government has this kind of assets. The value of these assets could have offered at least 100 people in her county decent medical services and avoided numerous deaths, which we are unaware of. So basically, we have a trending hashtag now where I don't know who the sponsor of this is, but they are saying sack all doctors. How do we try to convince Kenyans that you are not identifying the problem with us? Doctors are also Kenyans who are seeing this burden and that we all need to get out of it. How would you what else can we do better?
So, to solve a problem, I think a lot of problems are not solved because we mix a lot of things. Just to use your example of the Kirinyaga governor, you see, that may not be related directly. So if you think that the Kirinyaga governor, for instance, there is a problem, then there are people to look into that, for instance, EACC and things like that. But it gets lost if you try to mix it, because now they say, oh, you're political. So normally we like to start our solutions from the end. This is the problem. What is the cause? How can we solve it? So normally bringing in personalities prolongs a problem. And I'm sure you have in your questions, one of the questions being impeachment of the cabinet secretary
True.
of health. You see, so you would ask yourself, how would that help? Because you are asking, how would this what is the problem? So the doctor strike, for instance, how would that help? The political wing would benefit from the doctor strike, and the political wing are very clever and sharp at capturing the moment for their own gain. So they have brought a motion to impeach the president. So who is being talked about that? Is it the problem, or is it that they have
Person
brought a
representing
person?
the
You
problem.
get, and therefore we as leaders in doctors, we don't like getting distracted. I'll take you back to 2017 when the opposition tried to hijack the doctors thing. And we, by the way, we were appreciative of the opposition because they came and helped. They even gave us legal counsel, representation pro bono, and that helped. But where you come to a rally and you say, oh, yeah, that government is bad, we say, no, you address the problem. Don't hijack, because now it will be looked at politically.
You're changing
You're changing. So you're using it for your benefit,
gain, yes.
as opposed to solving the problem. So what are we saying? Does impeaching the CS of health solve the problem? As you say, we've defined our problem. Our problem is very clear. Interns need to be posted at this amount of money. One, just post them. But the Ministry of Health is actually responsible for that. They should have budgeted for that. And secondly, there is the other person called the Treasury. The Treasury have people who think that interns, medical interns, should not be paid. And that's another problem that needs to be solved. So we solve our problem here at the Ministry of Health. Have you done the budget? Have you taken it to ministry? And it is the same ministry who are supposed to go and tell Treasury, show them the importance of doctors and paying them at that, by translating it and saying, you see, if you pay doctors at this, they will treat the population. The population will get sick. They'll pay tax, this amount. You see, so if you have a sick population, then you're draining the economy. You see, so that's the role of the Ministry of Health. And Treasury should not start coming in and think that we are numbers. And oh, those are 1,000 doctors. No, they're not 1,000 doctors. They are doctors who themselves require to be well for them to make other people well. And therefore, so that when the population gets healed, they are able to contribute to the economy. You see, so throwing babies with bathwater, things like that. Impeaching us, yes, that's a red herring. I don't know. The governor of Kirinyaga has this amount of money that can. No, that's a red herring. That's she's allowed to acquire property and things like that, you see. But if people think that it's acquired wrongly, then there are other bodies that are supposed to follow that up, and the law come into action.
To come to your point, we have seen that when this strike was starting up, before it even matured to become to this level, we saw the CS come up with statements saying, I was not here before when the CBA was signed, but we will sign a new CBA from this time going forth. That is point number one. Point number two was the change in the terminology used to describe the medical intern to make it seem like a student. Part number three, we have seen threats being issued to doctors that if you do not turn up for work because of the industrial action, you will be sacked. And I was one of the people who got that application near some of the parastatal hospitals and county hospitals looking to employ. It was a divide and conquer tactic, but still the industrial action has been there. And she has, in a way, she has been able to make or incorporate this burden and ministry in herself. So I would understand why many people would look to impeach, but I wouldn't be able to get why, if she has incorporated herself as the person behind all of this, don't you think the impeachment would be necessary?
So those are weighty questions and they're loaded. So a government is not a person. A government is there in perpetuity. So whether you're there or not, you come and go. And then I always and probably just to take back and give a reflection is that we told people in previous time, your governor will come and go, your doctor will still be there. Your president will come and go, and your doctor will still be there. Uhuru has gone. Now we have a new president. But the doctor is still the same one treating the same people there. And that's one aspect of it. So the government is in perpetuity. Contracts entered by the government, you cannot now say you are new and you won't fulfill them. Why are we paying back the debts that were borrowed in the previous government? It's because the government is in continuity. So the same argument that the CS is making, then we can as well argue that the loans we have, we don't need to pay because it is not us who took, you get. So that argument does not hold on. Secondly, when a cabinet secretary ascends into office, there's a handover, and you're handed over everything that is continuing what you do. You might have your brilliant new ideas of what you want to do, but the previous agreements are there and you've been handed over. Thirdly, a collective bargaining agreement is collective and bargained. So what happens when a CBA expires? And this is probably why they're having a difficult time with this. It continues as is until a new one is negotiated. So if she wants to negotiate a new one, that's good. In fact, the government has been delaying negotiating a new one, thinking that this one would expire. No, it doesn't expire. A collective bargaining agreement actually continues to apply until a new one is filed in court. And we are very happy to negotiate a new one because first salaries are never negotiated backwards. In fact, a new CBA will have higher salaries for interns and every other doctor, plus new benefits because of the previous. We are bargaining, we are saying the cost of living has gone up. So there's no problem. We are waiting for actually a bargaining for new for the union to bargain a new one, which the rules of the game apply. And that's the reason they're having difficulties, even trying to annul and, yeah. So when people cannot change things in the law, normally governments, they try to do it by force. But unfortunately, this one has led to an industrial action.
That's unfortunate. And we have seen the transition. We have seen the government try to transition from NHIF to SHIF, with, again, the cabinet secretary labeling the previous NHIF scheme to be full of cartels.
Okay.
What did you say? Who are the cartels in this context?
The Social Health Authority is a body that has been enacted to replace the National Health Insurance Fund. That is in line of one of the 6 pillars of a healthcare system, which is healthcare financing. The 6 pillars of a healthcare system The most important of it is the human resources for health, because without them, then the health system cannot move forward. Without a doctor, everything else is irrelevant. You get what I mean? Because why? A person comes to the hospital to see the doctor to get well. And if they don't see the doctor, then everything else. And so HRH is the most important. After that, we have health care, we have governance and leadership to align everything to ensure that everything goes into providing the final output of the healthcare pillar, which is service delivery. When someone comes to hospital, they want to be treated. The service delivery is that they have come to hospital and they came out treated. You see? So you have HRH, you have governance that has put systems in place and said, if you come here, this is where I go, these are the leadership, these are the number of doctors we need, and service delivery at the end. In between here, then you need money, healthcare financing. And the money is on the side of the health facility and on the side of the client. You get the client must have ability to pay for that particular service. And ability to pay is not necessarily money, but it's ability to pay. And in between there now, the things that you prescribe like medication, then that's commodities. So healthcare commodities and now all these things can put in reports and all, then that's now the IT. You get? So those are the 6 pillars of a healthcare system. So social health authority is coming to address healthcare financing from the point of the person seeking the service. Get? As an association, we have advocated for a tax-funded, public-led healthcare and universal health coverage model. So what does that mean? Ideally, we would have a tax allocated to health, and that's the one that is used. But that's neither here nor there. So they have decided they have 3 funds managed by the Social Health Authority. The first one is the contributory scheme, which is a social health insurance fund, which they have proposed to charge 2.75% of your gross salary, wherever you are.
Okay.
So you contribute to that. So that money will be taken to long before the SHA came, Social Health Authority. There was the National Hospital Health Insurance Fund. That's where we were paying money, and someone who had a NHIF card and had contribution had certain benefits to it. This is what the Social Health Authority card, for instance, will give you. So money is collected that way. Then there are 2 other funds that are said to be tax funded. They come from the Exchequer, which is the Primary Health Insurance Fund and the Emergency Critical Care Fund. One of the rationales of the ECCF is that health is a right. If, for instance, someone came here with an emergency and this is a health facility, you'd need to treat them whether or not they
Regardless, yes.
are paying. But that was the challenge, you see. And so this fund is trying to treat that, meaning that there'll be some fund saying, you claim that I treated this guy, it was an emergency, pay me, you see. So those are the ways in which the government is trying to sort this, what is called healthcare financing gap. Of course, there have been debates about the way it is being done. One of the issues that civil servants had with this new scheme is that previous benefits were scrapped off. And the advice they were given is that go back to your employer, same government, to give you benefits, you see. So the medical cover of civil servants had been given to NHIF. So it used to go directly to NHIF over and above the payment of NHIF, like 1,700 to NHIF, and that was used as a premium. So the big question, and that is raising an issue, is 1, do you get back your medical allowance? And 2, which scheme will you be under by the same government that has scrapped and introduced her. So those are the discussions that are ongoing. Another important law that was passed was the Facility Improvement Fund. So FIF Act means that if a health facility, a public health facility is generating income, that income should be plowed back to the facility to help continue improving services. This was there before devolution. But at devolution, what happened? All the money now was collected by the governor and taken to the governor. So whether or not you're making money at a health facility, that money is not necessarily used at the facility. So it was going to the county pool, and they decide whether or not to give it back and how much. So that act will be a major boost to healthcare financing of public health facilities and the services.
Okay. So this takes me to another question. You have mentioned the devolution, and we have talked about the revenue generated by individual facilities, either level 4s, level 5s, whatever it is. One information I'd say I'd want to relay is there is a misappropriation of funds within certain level 4s, level 5s, where the income generated in one certain hospital, I will not say the name, was quite low, and it was almost dead until a change of leadership was brought, and it was able to generate about 40 million of revenue once a month. Do you think this revenue, together with this devolved government, where again this revenue is coming back to this county levels, if we continue with that scheme, will it be again trying to put out a fire with petrol?
When I was made a medical superintendent in Isiolo District Hospital in 2007, one of the problems that was facing health facilities at that particular time was money. There was no money. So a policy was put in place to help reverse these trends. And it was a policy that was generated at the Ministry of Health and cascaded downwards. So it contributed to the performance contract of the Permanent Secretary of Health and went all the way to the individual institutions. So in that particular facility, one of the ways that we said to improve the situation and therefore improve the services was to increase revenues. How do you increase revenues? You increase the services that are being offered. And we worked a way of, and so what did we decide? We made it an internship center. Yeah. So once it became an internship center, then all the services were offered. Service delivery was good. Two, to reduce leakage, we put in measures of how to reduce leakage. And there were very many ways in which money gets lost. There is something called a waiver. So there are sometimes some people come and say they can't waive. But we noticed that some people used to waive the next day because people have left at night. But there was some form of corruption in that. Some people are sent money, you allow the person to go. So we said that if anyone escapes from the ward, then the people who are in the ward are the ones to pay. So that stopped the loss of money by that system. We put in an electronic system. It was a manual system of receipting. And the electronic system on day one improved the revenue 3 times. So manual versus electronic. So the money getting lost got finished. We also had trainings on anti-corruption, so to speak, and we also had incentives for departments that were bringing in more revenue. So we say at the end of the year, if your department hits this target, then we will send all of you to a conference. You get,
Mm.
and that really incentivizes. So revenue generation and loss of money from facilities is very individual, and it also depends, as you put it clearly, on the leadership. What are the leadership? How is the leadership guiding? And as I told you, one of the health pillars, leadership and governance, has a direct relationship on revenue generation and expenditure. So these FIF, one of the effects of devolution on revenues of facilities is that because the money was not coming back, then people were not incentivized to actually, increase it or do anything. So it actually dipped as a result of that. So when people find ownership in what they're doing, you're saying, yeah, we have improved service and all, then some people are incentivized. At the end of the day, you are given sponsorship to a conference, for instance. Then that becomes a center in which you can mobilize, increase service delivery, and increase revenue generation and decreased leakage.
I'm genuinely looking forward to a nation where everything is running smooth. And I think we've come to the end. And would you have any final remarks before we do the outro?
So the current situation that we are having is easily solved. The Ministry of Health just needs to post medical intern, budget for because there are new ones coming in, budget for the ones who are coming, and push Treasury to release these monies. We are currently in the budget making cycle, a period. The budget is being read in June. So we need a lot of input from the doctors and professionals to actually push the ministry to push in these budget items, because when items are not budgeted, that's when an excuse is made.
Yeah, we
that
don't
you
have
can.
the
So
money for it.
we don't have, because it was not budgeted for. So that's the work of the Ministry of Health, and we need really to budget for all the items that we need to budget. And we hope that this will be resolved very soon, so that health access is given back to the people of Kenya.
Thank you. This was an eventful episode with quite a short time to unpack so much. Thank you, Doc, for taking some time off of your busy schedule to not just educate us ourselves, but enlighten the Kenyan public and even globally on the plight of doctors and healthcare workers in Kenya. We would advise our audience to continue having these conversations at home, in schools, in their offices, in their churches, because it is a necessary thing. And finally, the message I think would both put across is that it is possible to have fast, affordable, efficient, and effective healthcare. We have come to the end of the pod. You can chip in with questions, comments, or suggestions, and be sure to like, subscribe, and share. Laughing Lab Coach. Peace.